Hello, my name is Tracy George. I'm from the University of Utah and ARUP Laboratories, and today I will be discussing the hematopathologist's role in the diagnosis of acute myeloid leukemia. These are my financial conflicts. There are 3 learning objectives for this lecture: helping you understand which tests need to be performed for AML, recognizing how these tests help classify the different types of AML, and discussing updated testing guidelines for AML from the College of American Pathologists and American Society for Hematology. This is the agenda for today, and I'd like to begin with definitions of acute myeloid leukemia and the pathology behind this. There are 2 major categories of neoplastic hematologic disorders: leukemias and lymphomas. And leukemias involve the bone marrow and peripheral blood primarily, whereas lymphomas are concentrated in lymph nodes and other organs. When we think about acute leukemia or leukemia in general, there's acute and there's chronic, and it all depends on time. So acute leukemia in general, if untreated, leads to death in weeks and months, whereas chronic leukemias lead to deaths in months to years. Acute leukemia is a clonal proliferation of hematopoietic stem cells, and these are classified by the state of differentiation of the predominant cell type. And we often think of AMLs as being either myeloid or lymphoid, and that's depending on which precursor that it arose from, either myeloid progenitor cells or lymphoid progenitor cells, and sometimes, very rarely, they're biphenotypic. Myeloid progenitor cells can lead to proliferations that demonstrate either neutrophilic differentiation, monocytic, megakaryocytic, or even erythroid differentiation. So we have different techniques in the laboratory to separate out myeloblasts from lymphoblasts. And we do this because the treatments differ for AML from ALL, or acute lymphoblastic leukemia. The first technique is morphology. And the appearance of cells under the microscope can tell pathologists whether they look like myeloblasts or lymphoblasts. And in particular, if we see our rods, which is that pink rod-like crystalline structure in the cytoplasm of this myeloblast, by definition, if an hour rod is present, this is a myeloblast and this is acute myeloid leukemia. We also can perform cytochemistry. This is a cytochemical stain for myeloperoxidase, which stains blue, which shows that this myeloblast contains myeloperoxidase staining granules in the cytoplasm. And again, by definition, this is acute myeloid leukemia. We can also use flow cytometry to separate out myeloblasts from lymphoblasts. Flow cytometry looks at fresh cells labeled with different antibodies and looks at their light scatter, and that will give us information about cell size, internal complexity, and the state of differentiation of the cell, whether it's immature or mature, and whether it has myeloid markers or lymphoid markers. And that allows us to separate acute myeloid leukemia from acute lymphoblastic leukemia. We can also use immunohistochemistry, which is performed on actual tissue sections, to help identify immature cells and separate myeloblasts from lymphoblasts using certain markers. The definition for acute myeloid leukemia is fairly straightforward. You must have 20% or more myeloblasts in either blood or bone marrow. There are certain types of AML that can have recurrent genetic abnormalities, such as the 1517 translocation or 821 translocation or inversion 16, where by definition this is acute myeloid leukemia with or without 20% blasts. Here is an example of what acute myeloid leukemia looks like on a bone marrow aspirate smear. That's the wet part of the bone marrow that you aspirate out. And you can see there is a proliferation of clonal cells that are large in size compared to a red blood cell with high nuclear to cytoplasmic ratios and smooth chromatin in the nucleus. We also take out a piece of bone and look at the bone marrow and bone from patients. And as shown at right, this is a tissue section of bone marrow that has been fixed in formalin, decalcified, made into a paraffin block, and then thin sections are cut and stained. And this is a hypercellular bone marrow, meaning you have more cells to fat than you should normally see. We also perform cytogenetics on the bone marrow from patients with AML. In cytogenetics, we grow the cells or culture them, and then we arrest them in metaphase with colchicine. The cells are fixed with glacial acetic acid and methanol, then dropped onto microscope slides, which burst the cells and spreads the metaphase chromosomes. Routine G-banding is performed with trypsin, which gives each chromosome a distinct banded pattern, as shown here, that allows for identification of discrete regions along each chromosome. Chromosomes can then be classified and examined for imbalances by cytogeneticists who are very skilled in this. And so you can see in this example, the arrows show where the abnormalities are, and then this is reported in a very standardized fashion as shown at the bottom. We can also do rapid techniques such as FISH or fluorescence in situ hybridization. This can be performed directly on fresh cells with or without growing them first. We use fluorescent labeled probes that are directed at chromosome targets as shown above. This allows for rapid detection of selected abnormalities. So FISH has to be directed depending on the targets that you're looking for, whereas cytogenetics allows you to look for all abnormalities. Why do this? Because cytogenetics are important. In this pie chart shown here, you can see that using cytogenetics, you can classify patients into different subtypes of acute myeloid leukemia. And that has importance in terms of overall survival. Whereas patients with certain recurrent genetic abnormalities, such as inversion 16, 15, 17, and 821, have a better overall survival than those with, say, 11q23 AML. Mutations are also incredibly important in AML, and we now know that AML results as a direct consequence of different classes of mutations, whether it's class 1 mutations that affect proliferation and survival with FLT3, KIT, and CABLE as some of the genes involved, class 2 genes which disrupt differentiation such as the PML-RARA, RUNX1, RUNX1T1, and CBP alpha, or there's class 3 genes that affect epigenetic dysregulation, such as TET2, DNMT3A, and EZH2. And in fact, we're now understanding that there's the clonal architecture of AML, and that this can differ at diagnosis and at relapse, where in this slide shown here, each color represents a different genetic profile. So it's not just that AML is one disease, it's a population of different clones. And when patients are treated and then relapse, they can relapse with different clones, major, minor, or treatment-related, or even evolution of an ancestral clone. We know that AML is incredibly genetically diverse. And in fact, in one analysis of 200 patients, more than 99% had at least one mutation associated with the disease. And some of the more common genomic mutations include FLT3, IDH1 and 2, NMP1, CBP alpha, KIT, and DNMT3A. But the story doesn't end here. In fact, the majority of AML patients have multiple mutations, as shown in this Circos diagram, which depicts the relative frequency and pairwise co-occurrence of mutations in patients with newly diagnosed AML. So these are the tests that you need for the diagnosis of AML. You need morphology, you need immunophenotyping, which is usually flow cytometry, And you may sometimes also use cytochemistry and immunohistochemistry. You have to have cytogenetics, and increasingly fish studies are also important, as well as molecular genetics. And what are the specimen types that you're examining in patients? We examine peripheral blood in the form of peripheral blood smears and CBCs. We examine bone marrow aspirate smears, where we take the wet part of the bone marrow and smear it on a slide, air dry it, and stain it. We also examine bone marrow biopsies, where we take out a little piece of the bone and marrow. And in this, we first prepare touch preparations by gently taking the fresh sample and touching it to the slide, and air drying and staining it, and then also preparing bone marrow biopsy slides where we fix the cells in formalin, we decalcify it, embed it into wax, and then cut very thin sections and stain them.